Hello, this is Jeff Weisgarber. DDME is offering a series of educational videos to our valued customers. The purpose of these videos is to provide the latest information available on a variety of topics. We hope you find these videos beneficial and would enjoy hearing from you. What we're going to do today is we're going to talk about bruxism as a sleep disorder and also its relationship with the airway. And on that number 2, I said associated or not. It's definitely associated. I should probably rephrase that. I also want to spend a little time talking about why we use the term airway in our conversations rather than sleep apnea. There's an important reason why we do that, and I'm going to share with you why we use that term. Number 4, measure no. DDME is a company that's primarily made up of medical people with a medical background, and when we came into dentistry, we just felt that there was a lot of reasons why a dentist would be interested in just finding out for sure what the issues were rather than using their skill and experience. Number 5, we're going to obviously talk about the bruxism monitor and the benefits of testing patients, even patients that you may not think would benefit from a test. We want to share with you why we believe almost all patients that are sitting in a dental chair should be tested. Occlusal splints. I'm going to spend a fair amount of time talking about occlusal splints, and the reason being is because we actually measure so many patients, we have kind of confirmed a suspicion, and we're going to talk about the effect splints have on patients. And then number 7, we're going to probably have the biggest section of time, and Bill Ross, the CEO of DDME, is going to talk about our vision on what the future of dentistry in this area will look like and how we'll contribute to that vision. So that's what we're going to talk about today. Why measure the airway when we're talking about bruxism? Today that's not such a profound statement. When we started 5 years ago, it was. People thought that for the most part, bruxism was maybe related to the airway issues, but there wasn't convincing evidence, and to be honest, there's still not convincing evidence that's been researched and published in peer-reviewed articles. We want to change that, but without question, there's a large amount, if not most, of tooth destruction from bruxism are triggered from airway issues based on what we've actually seen, and so that's one of the reasons we believe so many patients should be tested. So, having said that, bruxism, as it's a fairly vague term, meaning a lot of things and different things to different people. But in general, when we talk about bruxism, what I mean is parafunctional EMG activity that occurs while a patient sleeps. And as a result of that, it is a sleep disorder. It's an official sleep disorder listed in the medical journals as a sleep disorder. The reason that I highlight that is because even though it's listed as a medical condition, it's essentially ignored by the medical community, primarily because it's considered a dental problem. So a lot of people are interested and are actually surprised that every PSG, every full sleep study that's ever been done since the beginning of doing sleep studies, we've recorded EMG activity on the jaw. Maybe not necessarily the masseter, but we have sensors there, but we essentially ignore it for the reasons I just stated. In the dental field, dentists weren't generally monitoring or measuring bruxism or parafunctional EMG activity. They were basing the treatments on damage that had been done or theories that they hold, and there are numerous theories there. One of the reasons that we like to emphasize measure and know is because there are so many theories on what constitutes bruxism and its causes and so on and so forth. So we essentially say, whatever your school of thought is on bruxism, we are proponents of measuring your patient regardless of what you think or theories that you have or what have you. We just, our position is we'll just measure and find out what's going on. And just to kind of put a point on it, the Mayo Clinic has made it very clear in no uncertain terms that sleep bruxism is a sleep-related movement disorder, and that essentially reasons why bruxism occurs, and oftentimes we know what those reasons are. So that is fairly well accepted in the medical community. So let's talk about measuring nocturnal or sleep bruxism. There's been a little bit of research done on defining what is parafunctional EMG activity and categorizing the types of parafunctional activity into clenches, grinds, and then RMMA or kind of mixed episodes. So there's definitions for these types of events, and the good news about those definitions are that they're very easy to detect. The masseter is a very strong muscle, as we all know. The waveforms that we're measuring are obvious, and it was fairly simple to create auto-scoring algorithms that could detect the frequency and define the types of these events. After we started measuring these events using these algorithms, it became very quickly soon that we also needed to figure out a way to measure the strength of these events, and we're going to talk about that a little bit later. The existing bruxism monitoring in the events that I was just referring to, just as we all know about AHI, the apnea-hypopnea index, we have a similar type of index for bruxism. It's called the BEI, the Bruxism Episode Index, and that's essentially the defined clenches, grinds, and rhythmic activity that we see in the masseter are all counted and kind of summed, put an index on it. So just like with an AHI, if somebody has an AHI of, say, 10, we consider that mild. Somebody with a BEI greater than 4 per hour, we consider that significant. So we do have an objective measure now that's been fairly well tested and accepted. We find that the BEI, as important as it is, it's not the whole story. And there's scenarios that occur fairly often that just knowing the frequency of these events can be misleading. So we are going to DDME has spent a fair amount of time and effort developing a way to measure strength of events. So when you have the strength or measure the total energy of the events that we're talking about, in addition to the frequency, we end up getting a much more thorough picture of what's going on. So we can kind of predict patient has a high frequency but low strength. We're not surprised that maybe that patient's teeth are damaged. On the other side of the coin, maybe a person has a fairly low BEI, below 4 per hour, but their teeth are destroyed. And in those cases, we see a very high energy expenditure on the masseter, even though all that energy is exerted in a lot fewer events. Okay, so when you have a BEI and you measure the strength, when you combine those two, it's like having the AHI and the ODI. So I kind of liken it to that. Okay, how do we measure the strength? Okay, so what DDME did is we've developed our own software that assesses the total energy expenditure of the masseter. And what we do is we have, at the beginning of the test, the patient bites down right before they go to sleep as hard as they can 5 times. You always just say, clench your teeth as hard as you can 5 times. And then what we do after the recording is completed and downloaded to us, we measure those 5 clenches. We have that patient's waking maximum bite force. So then we have, and we assign an energy unit to that, and then we use that energy unit for that patient's calculation for how much energy they're expending during the night. Very interesting things. We've seen very interesting things, and I won't plow into too much detail on that, but suffice to say a lot goes on in the masseter that many of us would be surprised at the level of activity that we see. Once we've calculated the strength using the biocalibration, we end up with some numbers. So just like we have the BEI, we also have kind of similar numbers for energy expenditure or energy units. So in this case, on the slide that you're looking at, the average clench on the patient that we're using their numbers on was 85 EU. So when you see a clench, 85 energy units were expended on that single clench, and we use that and that energy unit, and we calculate it through the night, and you can see that we can very accurately predict how much energy the masseter expends during the night. And that becomes critical when you combine it with the frequency to assess really what's going on with the patient at night with regards to the strength of their clenching and grinding. We have a good method to measure frequency and strength of bruxism. And when you take into account that we can now predict what triggers all that energy expenditure, and what I'm getting at is what's the link between the airway problem and bruxism. Okay, so I kind of want to spend just a moment or two talking about how is it that airway problems are associated to bruxism. And it's really actually not all that complicated. So when a person has a breathing issue, a hypopnea, an apnea, crescendo snoring, and then there's a list of more subtle breathing disorders such as upper airway resistance, respiratory effort, arousals. When any of those events are detected, because when we do our studies, we record the airway with a very sensitive instrument on the same time axis as the masseter that I've been talking about, we can see a temporal correlation between all these types of respiratory events and a clench event or a grind or what have you. And so what's going on there is that there's some type of airway issue, and the theory becomes now as in an effort to make the airway patent, the central nervous system triggers a series of activities that, so you hear people say, oh, bruxism's not related to the airway, it's a central mediated event. I 100% agree that bruxism is a central mediated event. However, the reason that the central nervous system initiated the event was because of the airway problem. Okay? So a lot of times people say, oh no, Jeff, I disagree with you, it's central mediated. And I say, no, we actually do agree. And for this reason, we can really identify the vast majority of patients, what's the cause of the bruxism. Okay, so what constitutes a CNS response? 5 items I've listed there. One is movement. So anytime the central nervous system kicks in an effort to restore normalcy, there's a lot of times there's movement. A person can move from their left to their back, or what have you. Number 2, what we're primarily interested in is the parafunctional EMG activity. The popular theory there is that the reason for that is to tighten the airway muscles in an effort to restore them to normalcy. So the clench is an effort to restore the airway. There's a decrease in the amplitude of the pleth waveform, which tells us, and what that means, it's a fancy way of saying the patient had an arousal. Okay, so anytime you disturb the sleep, that's not good for you. So we see this over and over again, that we see the patients having some type of subtle arousal. They may not wake up fully, but they do have a change in their sleep pattern. Oftentimes there's an increase in heart rate. Okay, so a simple increase in heart rate is not that big a deal, but when you do it hundreds of times a night, it takes a toll on the cardiac system. And then the work of breathing changes. And so one of the issues there is if you have constant increases in work of breathing, that's also detrimental to the patient's overall health. So what triggers these that sequelae of events then? Apneas and hypopneas. And we've known that for a while. I mean, you see an obstructive apnea, and then at the end of it, you see a clench. It's not hard to figure out that maybe that obstructive apnea triggered that clench. What's new is, in reality, what we've seen, and at this point, we've recorded coming up on 1,500 bruxism studies now, is that actually the more subtle respiratory issues are more likely to trigger a clench or a grind than the obvious apnea and hypopnea. And because the more subtle events are more likely to trigger, one of the frustrating things that the DDME has faced is most instruments used to measure sleep don't detect some of these more subtle respiratory issues. So you won't see the triggering event. The instrument that we're going to talk about in a little bit does detect those subtle events, and we do see that it's almost the more subtle the event, the more likely it is to trigger a clench or a grind. 3 and 4 are the subtle events that I'm referencing or talking about, which is upper airway resistance or flow limitation, and then respiratory effort arousals, which is caused when you limit the air passage. You have to increase your effort to get the same volume of air in because you're you're pulling air in a smaller or compromised airway. Okay, and that increased effort is often associated with clenching and grinding. Without question, in my mind, the airway has a very elegant mechanism to restore normalcy, and that mechanism is a clench or a grind. And there's a number of people that have researched this. Dr. Simmons, who I've known for years and years, and Ron Pren, who's the dentist that worked with Dr. Simmons. They've done quite a few studies in this area, and they would agree with what we're saying today, that the airway and the bruxism are linked. There's a highly cited pilot study that has to do with putting splints in known apneics and what happens to the airway when you put a splint in. And I'm going to talk about that when I talk about the challenges of using single arch splints to protect the teeth. Okay, so this is going to get interesting here in just a second. We've done our own set of studies on that topic, and the chart that we're looking at is actually not apneic patients like the previous pilot study, but these are patients that were seen by a dentist long before the dentist purchased a bruxism monitor, and these were patients that the dentist did a 2-night study at our request, and we asked the dentist, just pick a patient or a couple of patients that you put a splint in and do 2 nights of overnight home sleep studies on those patients. A baseline with no treatment, and then a second using whatever splint therapy was used to protect the teeth. And we found that splints have a profound effect on the airway. And in fact, 10 of the 14 subjects that were done in this study, the airway got worse, and in some cases, the AHI doubled or more. So statistically speaking, 10 out of 14, that's a very high percentage of worsening the airway in the presence of the splint. So why is that so critically important? Well, if we agree that airway issues trigger bruxism, and the very thing we're trying to protect against causes the airway to get worse, there's an issue there. And it doesn't take a lot of intellectual horsepower to figure out what the problem is. So this is some of the data that we've been able to extrapolate because we're actually measuring and we know the effect of these splints have on the airway. I wanted to show you, my tendency is to be a little bit clinical, and I tend to talk in clinical terms, so I'm going to indulge myself on this one slide, and I'm just going to show you how the 2 types of events, airway events, lead to a damaging event, a damaging bruxism. The one on the left where it says flow limitation breaths, the software you can see, there's a series of little tiny orange boxes. The software has identified those as limited breaths, and you can see at the end there's a run of flow limitation breaths, and then at the end of that there's a clench. Okay. The image on the right, that's a frank obstructive apnea, and most devices can pick up the apnea on the right. The thing that we like about the monitor we use is it can actually detect the types of events on the left. The one on the right, though, is an obvious apnea. That long orange rectangle, that flat line there is a cannula, and there's absolutely no flow, and it's pretty easy to tell that in an effort to open up the airway, a CNS response triggered a bruxism. The heart rate also went up. The patient also moved. So those list of things that go on a central nervous system response all occurred here in an effort to restore the airway on that patient on the right. Okay, so having said that, let's talk about how we're able to detect the subtle and obvious apneas when in conjunction with the bruxism. So what's involved is doing a home sleep study, and home sleep studies have been getting a lot of press in the past few years, especially in dentistry. And there's a lot of devices out there, and not all devices are equal. We looked at almost all of them. The DDME is not a manufacturer of a device. DDME is a company that's looking to solve a big problem. In that effort, what we've done is we looked at a bunch of units. And again, we probably looked at all of them. I'm very familiar with diagnostic instruments. I developed them in my career. Bill, who's going to talk in a little bit, also has ran companies that developed sleep diagnostic instruments in addition to other medical devices. So we're very familiar with detecting sleep disorders, is what I'm saying. The device that we use is the best, has the best combination of features and ease of use that we found for dentists. Okay, so there's reasons that a dentist actually might want to know more than a typical pulmonologist or primary care. And I'll talk about that in a little bit. But the recording is simple. One of the things we like about the monitor that we use is for all that great data that it creates, it's very easy to use. Okay, there's other devices that are similar to the monitor that we use, but they're much more difficult to use for the patient and the office that's implementing it. The monitor we use is very simple. So you can see there's 4 basic steps to sending the patient home with the monitor. The patients do these steps at home. The device is issued to the patient at the dentist's office. Somebody in the dentist's office kind of spends 5 or 10 minutes with the patient saying, here are the steps, here's how you start the test, go home, follow these steps, and bring the device back in the morning. Okay, so those are the steps that the patients are given. It's very simple. We've, just in the short time that we've been working with Whitmix, we've done studies where we sent the monitor to a dentist with absolutely zero training, and they just figured it out and got perfect data. So we really like the fact that it's a very simple monitor to use. One of the main reasons we like the monitor is that it does pick up very subtle respiratory issues. Almost all home sleep monitors can pick up a hypopnea and an apnea. And to diagnose obstructive sleep apnea, that's all you need to do. However, a dentist needs to know more than just apneas and hypopneas. So what we believe dentists need to know is all the kinds of respiratory events that can lead to the bruxism. Because at the end of the day, we're, as dentists, focused on protecting the teeth and preventing tooth destruction. And if you don't know the cause, you're kind of blind as a dentist to figure out what to do. And so the reason that we like this monitor is it does pick up flow-limited breathing. And as I showed you a couple slides ago, that triggers as much or more damaging bruxism as an apnea or hypopnea. And then the monitor also measures work of breathing. Same story. Increases in work of breathing can trigger a brux just like an apnea or hypopnea. So if you care about protecting the teeth, you need to know this information. And in addition, we need to know if the patient has central apnea. That's just not a dental issue. Patients that have that type of problem need to get referred to a sleep lab or a pulmonologist right away, and that patient has no business being treated for their respiratory problem by a dentist. Okay? So the device that we use does all that, and it's very capable of performing those tasks. Okay, so I do want to transition a little bit. So we have a problem, bruxism. We know what the cause of most of bruxism is. We have a method to detect both bruxism and the subtle problems that trigger the bruxing event. Now we have to say, what are we going to do about it? Okay, so that's probably the most important question. So as dentists, we have 2 paths. There's the medical pathway, which is very popular, getting a lot of press. It's a little disappointing, the rate at which dentistry is picking up on the medical pathway for the amount of discussion time that sleep apnea gets in dentistry. There's not a lot of dentists doing sleep compared to the amount of press that sleep is getting in dentistry. We know why that is. So as a result of that, DDME has developed a dental pathway, a pathway specifically designed for dentists for the purpose of protecting the teeth, and in doing so, if we need to manage the airway, we do so in a very effective way, in a very safe way that may or may not include the medical pathway. If it doesn't, then we get the patient to a pulmonologist or a sleep lab, and I'm going to talk about that, the 2 paths in a little detail now. I've gone 25 minutes nonstop. Is there any questions before I move on here?
No, we're hanging in there.
Okay, all right. Just want to make sure, because I can go for hours and not stop. So okay. So let's talk about the medical pathway. It's fairly well known. Like I mentioned, sleep apnea and it gets a lot of press in dentistry. There's a path that's well known. Essentially, this is what the path is. The dentist, and there's variations on the path, but in general terms, I'm going to describe to you what needs to occur in the medical pathway. A dentist who's decided to venture into this area sees a patient, does an initial consult. The initial consult's not all that different than what they're already doing. We just add 2 or 3, 4 questions to what the dentist typically does anyway. And those questions are related to how you feel during the day, are you tired, witness snoring, witness pauses in breathing, so on and so forth. Based on the outcome of the consult, it's appropriate that a test gets done. Okay, so based on the consult, it's likely the patient will have some type of positive outcome on a home sleep study and a test is ordered. What we believe, and I think number 3, I might have been jumping ahead a little bit. Once the test is done, we believe that the therapy should begin immediately. And I'm going to just spend a quick second talking about why we believe that. In the medical field, the primary treatment for sleep apnea is CPAP. Most of us know that. CPAP is not entirely successful in a lot of patients. You know, there's a variety of percentages that say compliance is 50%, 70%, somewhere in there, anywhere from half to a third of patients that get prescribed CPAP don't use it. So optimistically, a third don't use it. Realistically, probably 75% or less use it, or 50% on worst case scenario. Just get prescribed CPAP and don't use it. One of the reasons is there's these long gaps from when a patient gets tested to when they get treated. And as any dentist knows, patients, when dentists tend to be kind of crisis intervention specialists. And when you're in a crisis, as a patient is when they go see a doctor for their sleep apnea, they're very willing to get treatment. If you say to a patient that's willing, come back in 6 weeks and we'll do a PSG on you, 6 weeks later, that patient isn't going to be willing anymore. Okay, same thing with dentists. If you wait, if there's long gaps in any part of the process, the compliance rates go way down. So number 3 is we need to start something right away. Now, once you initiate some type of treatment, we'll talk about the VXR Pro. Once you start that, number 4 is talking about, okay, so there's possibly some airway issue, and if there is, then a physician needs to get involved if you're going to tackle that problem. That's obvious. Most dentists know this. For as much alarmist talk that goes on in dentistry about, oh, dentists shouldn't be doing this, every dentist I know of welcomes the physician input with open arms and is eager to get a physician involved. That's not an issue. I don't know any dentist that I work with that says, oh, I don't want to use a physician. I'm just going to treat sleep apnea. We just don't see that. So the alarmist talk out there maybe is a little bit overkill. When we do see certain types of apnea or apnea at a certain severity, if it's severe, that patient needs to go to a sleep lab. And one of the jobs at DDME is we offer services, and one of the services we provide to a dentist is we keep them out of trouble. When we see a patient, maybe shouldn't even be seen by a physician and just go straight to the sleep lab, we'll tell the dentist that. But so the idea there is we do have medical oversight. Okay, and as a result of that, we do refer patients frequently to a sleep lab, and that's actually very positive for the dentist. Might seem counterintuitive. Number 6, you get a physician to sign off on the treatment. Number 7, an appliance gets made to treat sleep apnea. Okay, sometimes the prescription will be CPAP, so the patient gets sent off to a sleep lab in those cases. Sometimes the patient gets prescribed an oral appliance. In those cases, the dentist starts the fabrication process. And then number 8 is you get paid. Number 8 is probably one of the number 1 reasons why more dentists aren't getting involved in treating patients with sleep, is it is difficult for dentists to get paid for medical insurance. There's a challenge there. It's very doable. A lot of our dentists are very successful at getting medical reimbursement, but there is an effort there. Okay, so that's the medical path. Here's a kind of a sample report. On the report here, we talk about the bruxism, is it associated or not, but most importantly on the medical pathway, we do diagnose the patient with sleep apnea. You know, when we first started, I talked about bruxism as a sleep disorder. There's actually a code for sleep-related bruxism in the medical code book, the CPT code. 327.53 is nocturnal bruxism. That's a diagnostic code in the medical books. So 327 is sleep apnea. 53 modifier refers to the bruxism associated. So this is kind of what a report diagnosis or impression looks like. The recommendations that you see on the right need to be accompanied with every diagnosis from a physician. If a physician's going to diagnose, they got to make treatment recommendations. If you're not getting treatment recommendations, there's something wrong with your process. So every one of our reports has treatment recommendations, and that's just made by the physician's discretion on what they believe is appropriate for the patient. Okay. All right. Finally, I wanted to use this report to illustrate why we like the monitor we use. This patient had an AHI, the apnea-hypopnea index, was below 5, which is that number just happens to be, you can't, that's not diagnostic level. So this patient doesn't have sleep apnea. However, they have destroyed teeth. This particular patient had little tiny nubs for all their anterior teeth were little nubs. Okay, no sleep apnea. This is what gets confusing to dentists because they say, oh, the patient doesn't have sleep apnea, but their teeth are destroyed, so they can't be relieved. The problem is, in this particular case, the patient had upper airway resistance at a very high level. So they did have an airway issue, but it wasn't obstructive sleep apnea. Okay, so the airway issue was tied to the patient's damaged teeth. It just wasn't sleep apnea, and that's why we use the word airway as opposed to sleep apnea, and that's the purpose of that slide. Okay, so let's talk about the dental path. It's a little bit different. It's designed to facilitate a dentist doing a great job, just doing a good job of protecting the patient's teeth, taking into account the primary cause, which is an airway problem. Okay, and we'll talk about how this is different from the medical path. So again, we start with a consult, and number 2 is the same. Based on the consult, the test is ordered. Number 3 is the same. The VXR Pro gets implemented to get the patient treated right away. Okay, the report, number 4 is talking about a report that we have that, I talked about the strength of or the energy expenditure of the masseter. DDME is the only company in the world that makes that calculation. So we are very unique in that ability to be able to calculate the amount of energy. And as a result of 1 through 4, the patient ends up with protected teeth. The VXR Pro might be transitioned into a long-term occlusal guard. The VXR Pro comes in 2 iterations. Iteration 1 is transitional, inexpensive, made in a few minutes and sent home with the patient the same day. The second iteration is long-term therapeutic, made of acrylic, and the process is the same as sending any impression to a lab, and you receive back an acrylic version of your guard from the lab. It could be that the patient has the transitional version of the VXR Pro, and then they transition into some other type of appliance, completely up to the patient, or I'm sorry, the dentist. But at the end of the day, we need to get treatment started right away. Okay. Now, at the end of all that, number 5.
Can I interrupt?
Sure.
So the VXR Pro, so you're going to use that as an interim appliance. How do you verify that the airway's right with that? Do you have them do another test?
Thank you. I couldn't have paid you to ask a better question. Absolutely. When we talk about measure no, once you've fabricated the VXR Pro in your office, let the patient wear it for a couple nights and then do another test. Tests are only about $20. So it's very inexpensive to run a test. And you confirm you have a starting point, the baseline, you've done something, you now want to see the effect of what you've done. Does it have the desired effect? And you do exactly as you suggest. Do a second study wearing the VXR Pro and see what happens. It could be that the patient has a very positive response, and you know that the patient's a responder to that type of therapy. That's very valuable information. Even if you don't end up with the long-term VXR Pro, think about the value of knowing your patient's a responder, and then they can also tolerate the therapy before you go into something like a TAP Elite 3 or an Narval or some other sleep appliance where there's a fairly large dental lab fee involved. The risk of that fee goes way down because you already know, 1, your patient's going to respond, and 2, they can tolerate the therapy. So that's the primary idea there.
And if the patient's not responding, can you can you calibrate that VRX Pro?
Yes. Yeah, there's 4 settings. There's 4 mandibular positions for the VRX Pro, and we'll talk about that. We'll talk about the VRX Pro and those settings, and actually, I think it's 2 or 3 more slides.
Okay, and then just to jump in, so if you get then the position that works for the patient, is it easy then to use that to make your definitive appliance?
Correct.
Like, use that position.
Yes, absolutely. So
Okay.
the appliance comes in 4 positions, and when I say positions, in sleep appliances, we use the term percent protrusive. So the patient, you might go start with 50 or 60% protrusive, do a test, figure out you need to move it out more. With the VRX Pro, we're not necessarily titrating, but if you have an AHI, for example, of 15 and a Bruxism index of 4, and you put the VRX Pro in, and the AHI goes down to 10, and the Bruxism goes to 2, maybe you want to move the mandible out 1 more position and see if you can get your AHI below 5 and your Bruxism index goes to 0. And then when you do that, you know that you're close to the position you need to be in. Okay?
Jeff, I'd like to interject that on the dental pathway, you don't necessarily have to bring in a physician, because in many cases what you're doing is you're solving the bruxism issue, and the sleep apnea or upper airway resistance syndrome might very well go away when you use the VRX Pro, and in those cases the physician doesn't need to be involved because the dentist is really protecting the teeth, and he gets the information necessary to assess whether that was successful. If the patient has a risk of a lingering sleep apnea, then you might need to get the physician involved. The dental pathway is designed specifically that you don't have to have medical intervention.
Okay.
That's exactly correct. And you know, when you sometimes you learn, because you have objective evidence that the patient's not a responder, or the patient's much more severe than you anticipated. And in those cases, because DDME offers both the medical and the dental path, just as Bill said, a lot of patients won't need the physician. When they do, we'll know. So either outcome is very manageable, and we have a simple path to follow in both outcomes. But the idea here is you can tackle protecting the teeth without worsening the airway with a single arch guard, and you'll know the status of the airway at the end of the dentist task. And if at the end of the dentist task there's still a lingering airway issue, send them to a sleep lab. That's a great outcome for the patient, and it's a good outcome for the dentist. The dentist did a great job of protecting the teeth, and then the medical issue of sleep apnea gets managed by the people who do that for a living. So the you know, on this slide that I switched to, these are the numbers that you get from the dental path report. So it looks quite a bit different from the physician report that I showed you. There are recommendations on the lower right. You can see that there's recommendations there. In this particular case, the airway was not an issue for the patient, but they had the airway was managed or improved in the presence of the VRX Pro. So at the end of this, we have evidence that the patient's teeth are protected and there's no lingering airway issue. Okay, so the thing that we really like about the dental path is that when you protect the teeth, and doing so in the method in which we prescribe, oftentimes the airway issue is managed if there was one in the first place. I did also want to just highlight real quick the measuring of energy expenditure on a baseline and then a therapeutic level. So if you recall, we calculate the energy units based on the patient's calibrated clench, and then at the baseline here, the energy units expended by the masseter on the night of the baseline was 10,685 energy units, and in the presence of the VRX Pro, it was 2,300 energy units. So it was cut by 3/4. So the amount of energy or pressure being exerted by the masseter is going way down. So why is that? How is that different from a single arch guard? What we see in guards is these numbers actually, the masseter energy in the presence of a single arch guard goes up. Okay, so if a baseline is 10,685, you put a guard in, it might be 15,750. Okay, now granted, there's something between the teeth protecting the enamel, but everything else gets worse. Okay, so that's why we really want to focus on how much energy is being expended. So I'm going to transition now into the reason for the BRX Pro and why DDME developed such a device that really doesn't exist in dentistry up until the point that we said there's a gap. And the gap was there's sleep apnea appliances, they're ubiquitous, there's probably 100 varieties of sleep apnea appliances out there, and then there's single arch guards, which is a world away, and its complexity and use and how it gets implemented, the costs associated, and so on and so forth. So there was these two extreme ends of a spectrum, and right in the middle were most patients. So we thought, geez, there's all these patients that need some type of tooth protection, but they're getting a single arch guard, which isn't helping them. And then there's a very few number of patients getting oral appliances for a variety of reasons. There's only a few patients getting them, but a lot more patients need protection and without worsening the airway. Okay, so that's why we decided. That's why we kind of identified this gap that I'm referring to in the slide, and as a result of that gap, we needed an appliance that protected the teeth without worsening the airway. And in order to do that, we needed to create an appliance that just held the mandible in a known good spot. And it needed to be inexpensive and be able to use right away. So number one there, it's a transitional appliance. And transitional infers that you're going to go somewhere for your long-term therapy. But on any type of therapy, the sooner you get started or the sooner you treat the patient when the patient's willing to be treated, the better the compliance is. Okay. Another attribute to the BRX Pro is it's partial arch. So there's no posterior tooth contact. Obviously, there's no contact to enamel because you have the BRX Pro in there. But there's also no acrylic to bite into. So that's the kind of the concept of the NTI. Like we mentioned, based on the question, it is adjustable. There's 4 positions on for the mandible. So again, the goal is not necessarily to titrate like a sleep appliance, but we do want to find a good, comfortable position for the mandible. So when the patient goes to sleep, that mandible doesn't wander back into the airway. So that was the reason for the dual arches. And with those set of attributes, we're protecting the teeth and we're maintaining the stability of the airway. Okay. And here's the slide I was referencing with regards to the adjustments of the BRX Pro. If I had to, talk in just very quick general terms, it's a pair of partial arch impression trays with an inexpensive anterior hinge that has 4 positions. That's all it is. You fill the trays with PVS material, medium set. You trim it up, get all the excess PVS out of there once it sets, and you send the patient home with it. You pick a spot, what class bite are they? You kind of can get a sense of what position of the 4 options you have there. Couldn't be simpler. And at the end of 5 or 10 minutes, you have the ability to send the patient home with a therapy at the point in time which they're willing to be treated. This slide here is just kind of showing you the construction process. And then going from the transitional to the acrylic BRX Pro or appropriate appliance. Yeah, so that's the story on the BRX Pro. We've done some testing. This is a case study on a patient, 57-year-old female, been treated for bruxism for many years. We talked to her and she said she felt she was probably 75% improved, but still had some lingering symptoms, although her teeth were have been protected for years. She still had kind of what we would call symptoms related to TMJD. So with the BRX Pro, what we found is that we did a 3-night study on her. We did a baseline, and her AHI was 11, which is mild. We did her full lower arch, and her AHI improved, but was still diagnostic for sleep apnea. And then we did the third night with the VXR Pro, and the AHI fell well below 5. So the presence of the VXR Pro managed the airway. And we can see the same kind of trend in the oxygen desaturation index. So just like on our Bruxism, we have frequency and strength. We have two numbers there. For the airway, we have AHI and ODI. So the VXR Pro, the presence of the VXR Pro in this particular patient improved her airway. So let's talk about what we really care about and what's going on with the clenching and grinding and the energy expenditure. We did see some improvement with the strength with the single arch guard, but it was still fairly high. So her clenching was extraordinary on her baseline. So 8 per hour on her clenching and grinding is double what is diagnostic. So she had a very severe case with her full lower arch. Her expenditure, her frequency went down, but it was still very, very high. And with the VXR Pro, we had the best number yet. And we looked at the total amount of energy, and everything improved with the presence of the VXR Pro. And the total energy improved significantly. And actually, if you look at the bottom clench reading, the energy exerted wearing her single arch guard actually went up, and it went from 19 to 25. And the reason for that is because her airway was still kind of active in triggering events. And we can see that in this slide here. So we just see a dramatic improvement in the total amount of energy. So if you look at the total energy as 100% in baseline, the total energy went up by 20% wearing our single arch guard and went down to almost nothing with the VXR Pro, which is what we want. So we're protecting the teeth, but I believe more importantly, we're solving a problem. We're not just protecting the teeth. Okay. At this point, I'm going to turn the presentation over to Bill. And Bill, when you're ready, just let me know when you want to move on to the next slide, and I'll just advance the slides.
Thanks, Jeff. Jeff and I come to the dental area with a lot of medical experience. And as Jeff mentioned, the company that we ran, we actually were the first company to have diagnostic equipment for sleep medicine. It's the father of sleep medicine is assumed to be Dr. Up at Stanford, and he actually used our equipment. So I've been involved in the sleep medicine part of the business from the very conception, and there was basically no sales at that time. And by the time I left, it was probably about a $5 billion a year business. And since I've left the industry, it's probably more like a $15 billion industry. So sleep medicine really has evolved over the last 20 to 30 years. And Jeff is he's modest. And we talked about the Bruxism monitor. Jeff actually specified that the company that makes that monitor, we've specified the Bruxism software to them. So our whole intent at DDME was to try to bring the sleep medicine technology to dentistry to solve the unique issues that cause the tooth damage. So since we've been formed, we did bring the first nighttime Bruxism monitor, and we also, as Jeff has done, we've developed our own Bruxism software, and we've also developed an appliance that Jeff went through. Go ahead, next slide. So I want to, I'm a very naive person in the dental market, and Jeff has had quite a bit of experience, but I'm really sort of a medical guy, and there's an advantage and a disadvantage to that. The advantage or the disadvantage is I'm probably very naive about what it takes to bring things into the dental market. But the advantage is that I probably am at the 40,000 foot level, and I might not be tied to any preconceived notions as to how to do this. So this presentation that I'm going to do is really a 40,000-foot level presentation. If you look at the history of preventative dentistry for tooth decay, in the 1800s, before the 20th century, patients really didn't go to dentists on a proactive basis. If they had pain, they went to see a dentist. But the concept of a dental checkup and going to see a dentist every 6 months was a foreign concept. And then in the late 1800s, the first dental x-ray was done, and a collapsible tube for toothpaste was done. And today, if you talk to a dentist, every dentist would say, I practice preventative dentistry. And so over that period of time, dentists have gone from being reactive to being proactive as far as doing preventative measures. Next slide. However, if you look at tooth destruction, dentists are still in the mode of diagnosing tooth destruction after the fact. And when I first started to do some research on whether we wanted to do a bruxism monitor, when I asked the dentist how they diagnosed bruxism, they would look at me like, you're crazy. Now, I learned that in Dentist 101, and I go, well, how do you do it? And he goes, well, there's a certain fracture pattern that is on the tooth that indicates that they have bruxism. And then I said, well, how do you diagnose bruxism before you see the fractures on the tooth? And I would get a blank stare because there were no tools available to the dentist to be preventative with tooth destruction, and that's basically why we decided that we thought there was a opening in dentistry to provide tools that would allow preventative measures. So we introduced in 2012 the first monitor. Okay, next. So what we think is that dentists should do a dentist physics. What we mean is very early on, dentists do exercises. And on that example, we believe that you start doing oral cavity cleaning at the same time. And the reason is, what is the clinical benefit of doing that? Well, the benefit of the screen is only good if you have done something to change the course of what that patient would do. That's the whole purpose of having an EKG in medicine is to be predictive in case there's coronary artery disease. This is sort of the same way, and the outcome of doing it, it's estimated that 30% of to be screened have done something 50 that changed their outcome. And the clinical benefit obviously is that the patient would have had abnormal wear, don't have abnormal wear, and these were symptomless, and that they don't have. And maybe the biggest reason, probably from a medical point of view anyway, is that if you do early screening for OSA, you can avoid getting the comorbidities that OSA gives you, which are well documented in the medical literature. Next slide. So why will every office be screening patients for oral cavity disorders? We believe it is correct. And my experience, we probably developed in my background, well over 100 medical products. Every medical product we did that had a powerful clinical outcome were successful. And in this case, there is a powerful clinical outcome on the prevalence of the diseases that are out there. And so I think first and foremost, the reason why we think it's successful is we strongly believe we're clinically correct. Next slide. Okay, as Jeff mentioned, being clinically correct, so the dentistry has an opening to solve these problems, and We believe they do. And the reason is medicine does not proactively screen for sleep apnea. Medicine will only reimburse when a patient has already exhibited the symptoms. And the problem with sleep apnea is the patient may not know the problem with it until they are far down the path. And the comorbidity aspect of sleep apnea has already surfaced. The other advantage for is the fact that they are used to doing a preventative mode of practice, is that the dentist can actually build his own sleep dentistry program from the ground up. If you start screening, he will have his patients, and those patients, 30% of them over the next 10 to 20 years will have some kind of intervention, because there's such a large percentage of the problem. And the other reason we think that it's very appropriate now is dental practices are looking for new and something new in dentistry. That, whitening of teeth was there and it's disappeared. And if I look around in the dental market, I see a whole variety of things emerging that dentists are specializing in, but many of these dentists away from the main focus that we were trained for, which is the tooth. And the oral cavity screening is tooth-centric. The whole purpose of doing this is aimed at protecting the tooth. And so it's well in the focus of the dentist. Jeff went through this, and the problem that dentists have is they do not realize that they are causing a problem when they are putting in a single splint. When that gets well known in the field of dentistry, then everyone will need to be careful about what the position the patient is required to be treating for bruxism, and our measure and know is the solution. Next slide. Okay, we are developing products, and the part of the problem with diagnosing sleep diseases is it's a little bit of a complex process for a dentist to do. And we're developing a program where basically the dentist, do a consult, will show a patient, let's say it's the teeth that are good and that it might look like 20 years, just that he starts the script to avoid that from happening. And that's what he does. And then he schedules the patient to have with basic stuff, to have a sleep session, and he sends them. And the patient will have an ability to call, or the patient will be called by us, and we'll be able to lead to the connecting of the full sensors, and we'll know in real whether the signals are valid, and tell the patient to go to, and say the patient return, take the equipment back, and the dentist has a full oral cavity assessment that he can go through with the patient. If it's positive, he goes through the process of showing him what the issues are and pick the right appliances for doing it. And this process, dentists don't worry about all of the medicine being the start and the finish, or he doesn't have to worry about whether the study's good at night. All of that is taken away. A consultant and a cover up the problem, and everything takes for him. the history going to be two things, but a 15 years, steady dental. The price, if the pricing of everything is correct, we think that we can buy this and have it do it.
This is really hard to hear, Bill, if you're breaking up. I don't know, Jeff, if you can continue the discussion.
Yeah, I was thinking about doing that. So, Bill, you're cutting out. It's kind of progressive. So I'll just finish up with this last one.
Okay.
Okay. So, what Bill mentioned, when he first started was that, the perspective of taking bruxism to the preventive area of dentistry, and we've demonstrated that we can do that. And there's some barriers to that. The primary one being complexity, and we're working on a couple of products that will greatly simplify it. And as a result of simplifying the process and making it not unlike as simple as taking an X-ray or what have you, if we can capture the oral cavity screening as simple as you can capture, say, an X-ray, then we believe every single dentist office would be very interested in the type of information that our oral cavity screening provides. What's the condition of the airway? How is it interacting with bruxism? And so on and so forth. So because there's so many advantages to intervening early in both issues, bruxism and the airway, there's a huge, what we believe, health benefit to kind of moving this area into dentistry. And I personally, I believe that dentists are probably more equipped to manage this as a preventative process than the medical community. The medical community is still kind of focused on crisis intervention, and dentists, one, see their patients much more frequently than the physician, and two, if dentists have the ability to easily capture this information early, we could intervene in both airway and oral cavity issues much sooner than we believe would be otherwise available to any path that the patient has available to them. So we believe that what we want to do is when we say complete dental physical, that needs to include an assessment of the oral cavity, which takes into account the airway and the amount of bruxism. So by 2025, our goal is that bruxism will be preventable. The airway will be manageable in a much earlier phase of the disorder, and thereby eliminating or greatly reducing all the comorbidities that Bill talked about earlier. And if we make this screening process easy and inexpensive, therein lies the opportunity. So just like there's an X-ray machine in almost every dental office today, we believe there could be a screening, oral cavity screening device in every office, assuming that everything else is equal. In fact, I would go so far to say that an oral cavity screening probably provides more beneficial information for the patient's overall health than an X-ray. So at the end of our goal, at 2025, we want to have all dentists at least thinking about this, if not doing it themselves. So with that being said, we went over a little bit. It's 5 after. I think Bill and I have shared with you what we wanted to share, and at this point, we wanted to leave more time for questions, but now is the time if you guys have questions for us.
I apologize, my audio. Oh, I hear it. Oh, I know why.